Hey guys, what's up? Hope you're doing well. I just dropped a video on fluids and electrolytes, and I'm doing part two of part one. I will encourage you to watch the part one because in that record, I discuss in details everything we need to know about fluids and electrolyte for the NCLEX. In this section, I'm going to answer some questions which it will not be possible for me to cover all the questions on this topic. But in part one, the explanation was so detailed in a way that when you watch it, you'll be able to answer questions as far as the topic is concerned. And it would help you to understand some of the questions we're going to treat here. So let's get started. Okay, this is question number one. It says, the nurse assesses the peripheral IV site of a client receiving a doxorubicin infusion who has suspected extravasation, and after stopping the infusion and is disconnecting the IV tubing, which action should the nurse do next? You get it? A. Apply a hot compression to the IV site. B. Apply a cold compression to the IV site. C. Elevate the affected extremity. D. Attempt to aspirate the residual drug. Which is the right answer? Yeah, the answer is D. Attempt to aspirate the residual drug. This is a drug that is toxic to the vein. And like I said before, with potassium, you have to go watch that video. You can't escape that video. And the drug is already causing extravasation. You can see it's burning. There's a wound there on that side. And this drug is toxic in the vein. The first thing you have to do is try to attempt to remove any residual drug using a 1 to 3 ml syringe. Yeah, you have to aspirate and discard it. That's what you have to do. Hot compression should not be applied in this case, right? We don't need it. Anyway, cold compression could be okay, but the first thing, the drug has to be removed, right? First, try to remove the drug before you apply a cold compress. Um, elevating the arms, although elevating the arms for the first 48 hours is recommended, this should not be done until after the drug has been removed, right? Like I said. Yeah. Let's look at the second question. We have the nurse aspirate a central venous catheter prior to drug administration, but is not able to verify blood return. The nurse does not feel resistance when flushing or see any fluid leakage, swelling, or redness around the catheter site. Which next steps are appropriate? We have encountered this as we execute our function, our duty in our daily life. Select all that apply. A says flush the catheter with saline using 10 ml syringe and a push-pull technique. B, request that the client cough and reattempt aspiration. C, administer IV medication and observe for signs and symptoms of catheter malfunction. D, place the client in Trendelenburg position while attempting to aspirate. Trendelenburg means that the head should be down and the leg up, right? Yeah. E, follow institutional protocol to initiate a declotting protocol. Okay, which is you have to select two or more options. The right answer is A, B, and E, right? A, B, and E. We can't do C and D. Let's see why. Okay. Flushing the catheter with saline using 10 ml syringe and the push-pull technique, these are appropriate steps to verify blood return in the central venous catheter. Push means you flush, you push, like you do like this, okay, with the syringe. Push-pull. Instruct the client to cough before attempting aspiration is an appropriate step by trying to verify blood return. It's good, right? It's good. And he says initiating a declotting protocol per policy is appropriate. You know, you're trying to verify blood return, which is still okay. But administering IV medication, you know, and fluid should be performed until other steps are taken to verify proper placement of the catheter by assessing patency and blood return. Yes, that will not be an option at this time, right? Putting the client in Trendelenburg position to aspirate blood return is not evidence-based practice. There's no proof that when you put the client in that position, and it will be possible for you to get blood return. You don't have to do that. Let's see the next question. 3. Question 3 says, the nurse is caring for a client with heart failure. On assessment, the nurse notes that the client is dyspneic and crackers are audible on auscultation. What additional manifestations would the nurse expect to note in this client if excess fluid volume is present? Yes, we talk about excess fluid volume. We'll watch part 1. A, weight loss and dry skin. B, flat neck and hand veins and decreased urinary output. C, an increase in blood pressure and increased respirations. D, weakness and decreased central venous pressure. Which is the right answer? Signs and symptoms of excess fluid volume. C, an increase in blood pressure and increased respiration. This is a heart failure patient, right? You will see more of this when you treat the cardiovascular system, where you see CVH, okay? Like we said in the record, fluid volume excess is also called overhydration or fluid overload, and it occurs when fluid intake or fluid retention exceeds fluids needed by the body. We'll talk about that. So assessment findings with that are cough, dyspnea, crackers, tachypnea, tachycardia, elevated blood pressure, bounding pulse, elevated CVP, central venous pressure, weight gain, edema, neck and vein distension, right? Yeah, altered mental status or level of consciousness, decreased hematocrit. Okay. B instead is fluid volume deficit, okay? Flat neck and decreased urine output. Yeah, weight loss, dry skin is deficit, is instead opposite. Yeah. Weakness and decreased central venous pressure. No, it's instead increased central venous pressure. Okay, that's it. Number 4, let's see. The nurse is caring for a client with heart failure who is receiving high doses of a diuretic. On assessment, the nurse notes that the client has flat neck veins, you see, generalized muscle weakness, and diminished deep tendon reflexes. The nurse suspects hyponatremia. What additional signs would the nurse expect to note in a client with hyponatremia? Yes. Go watch the video. Oh my God. Hyponatremia. The capital O. What? Fluid overload. Okay? When you have fluid overload, what happened? there is instead decrease oxygen in the system because the fluid sodium, because the fluid dilutes sodium in the system. That's how you look at it. So which is the right answer? Muscle twitches, decreased urine output, hyperactive bowel sounds, increased specific gravity of the urine. We saw something, boborygmy. So the answer is C. Why did I say boborygmy? Boborygmy is another word for hyperactive bowel sounds, right? Yeah, abdominal sounds, those grumbling sounds in your abdomen. Yeah, that's what we're saying here. Hyponatremia. So, yeah, the remaining options are for hyponatremia. Hypo, po. The E, and I said the E stands for what? Dehydration. So you look at signs of dehydration. Muscle twitches, decreased urine output, increased specific gravity. Increased specific gravity because when there's dehydration, the urine is concentrated. So the specific gravity becomes high. But when there is fluid overload, hypo, overload, then we have signs and symptoms of fluid overload, which are what? Hyperactive bowel sounds, increased respiration, all the signs and symptoms of fluid overload. That's how you look at it. It's a technique. Let's look at question number 5. Potassium chloride intravenously is prescribed for a client with heart failure experiencing hypokalemia. Which action should the nurse take to plan for preparation and administration of potassium? Oh my God. Select all that apply. You need to go watch the first video. We explain all of it. If you watch the first video, you will just answer this question without any problem, okay? A, obtain an intravenous infusion pump. B, monitor urine output during administration. C, prepare the medication for bolus administration. D, monitor the IV site for signs of infiltration and phlebitis. E, ensure that the medication is diluted in the appropriate volume of fluids. F, ensure that the bag is labeled so that it reads the volume of potassium in the solution. I like this question. Select all that apply. Ting, ting, ting. The right options are A, B, D, E, F. A, B, D, E, F. C is not. Never, never administer potassium through like an IV bolus. Very fast. No. IV bolus, no. IM, no. Subcut, no. You must have a pump. You must monitor urine input and output. You must monitor renal function because potassium is excreted through the kidneys. You must monitor the IV side. We say potassium burns the veins. It can cause infiltration and phlebitis, inflammation of the veins. You must dilute with normal saline 0.5%, 0.9% normal saline. I don't know why 0.5 keeps coming in my mouth. I think I mentioned 0.5 in the... No, guys. 0.9 normal saline. And I don't edit my videos, so... Okay, so if you watch the first video and this one, you get the correction. 0.9% normal saline. Ensure the bag is labeled. Yes. Watch that video, you will see all of these. The last question. Do you want to do this one? Should I allow this one for you to do? Let's do it. The nurse is assigned to care for a group of clients. On review of the client's medical records, the nurse determines that which client is most likely at risk of for fluid volume deficit. Fluid volume deficit. So we are looking at clients' causes of fluid volume deficit, in other words. If you have this condition, you are likely to have fluid volume deficit. We said that in the first video. God, you got to go watch this. A client with an ileostomy. B, a client with heart failure. C, a client on long-term corticosteroid therapy. D, a client receiving frequent wound irrigations. Come on. And I emphasize on something. Which is the right answer? A is the right answer. I talk about ileostomy, coliotomy, right? The patient is passing physics and fluid through that bag, right? Ileostomy bag, colostomy bag, you know. So there's bound to be fluid volume deficit. Heart failure, when you have heart failure, you're bound to have fluid retention in you. So you have fluid volume excess or fluid overload. Long-term corticosteroid, they instead cause fluid overload, fluid retention. Steroid, client receiving wound irrigation. So I emphasize in that video, I talk about, do not be confused with ileostomy and irrigation. Irrigation means you flushing, you're cleaning the wound, and you instead give more fluid to the system. So it's bound to have what? Fluid volume excess. You got it? If you did not get it, watch the video again. I will not say forget about it. I will say, if you did not get it, watch the video again. Okay, guys, see you in my next video. Bye-bye.